The moment a breast cancer diagnosis is delivered, a storm breaks. You are instantly hit with a barrage of new medical vocabulary, urgent lab schedules, and complex treatment pathways to navigate. Naturally, the medical team immediately locks onto a singular target, attacking the tumor. But while they zero in on the disease, a secondary crisis starts to unfold for the person actually living with it. Physical and emotional side effects, like a sudden, severe inability to sleep, spiraling anxiety, and the sheer stress of managing daily life, often fall right through the cracks of a standard oncology appointment. Treating the cellular disease without actively managing how the patient functions day to day creates a dangerous vacuum in their care. There is a dedicated medical discipline designed specifically to fill this human gap. It's called palliative care. We need to clear up a misconception. Palliative care is not hospice. It doesn't mean a doctor has given up, and it's separate from end-of-life care. Instead, it's an added layer of support received alongside active treatments like chemotherapy or surgery. This approach establishes a continuous layer of symptom management that works in tandem with active oncology. If this concurrent support is so essential, the next logical question is exactly when a patient should start receiving it. A recent study highlighted by the American Society of Clinical Oncology looked at newly diagnosed breast cancer patients in India to test two different timing approaches. This chart establishes the two test groups. Group A relied on on-demand care, meaning they only received palliative support if they specifically asked for it. Group B received early integrative care, starting palliative visits within a single week of their diagnosis. After 3 months, the difference in their daily lives was stark. The early integration group saw their quality of life scores jump by 23.2 points, compared to a 14.7-point increase for the on-demand group. 70% of the patients who received early care experienced meaningful improvements in their overall well-being, which mapped directly to a sharp, measurable drop in their overall symptom distress. The clinical data points to a definitive conclusion. Waiting for symptoms to become unbearable costs patients a massive amount of their daily well-being. This proactive approach works because a palliative team steps in to collaborate with oncologists. They manage side effects like neuropathy or severe hot flashes early, intercepting them before they escalate into crises. And this support extends beyond the hospital bed to the invisible patients in any cancer journey, the caregivers, who silently absorb the massive logistical and emotional weight of the illness. Early palliative care gives these family members a clear roadmap for safely tracking complex medications, recognizing warning signs, and crucially, a dedicated space to process their own burnout. When you ease that intense burden on a caregiver, you create a ripple effect that measurably stabilizes the patient's own stress levels and recovery. Comprehensive cancer treatment requires structurally supporting both the patient and their immediate network from day one. A cancer journey takes a severe psychological toll. Patients often describe a jarring loss of autonomy, feeling like they are constantly reacting to the next blood draw or the newest wave of nausea. Early palliative care flips that reactive dynamic. By outlining what to expect and building a plan for symptom management ahead of time, patients feel prepared rather than cornered. Choosing this parallel track of supportive care is an active, deliberate decision to prioritize daily comfort alongside curative treatment. It puts the patient back in the driver's seat. Starting this care early allows a person to anticipate their needs and make informed choices about their daily physical stability. To get this parallel support, you have to actively request it by initiating a conversation with your oncology team. Bring these specific questions to your next appointment. Ask, is supportive care available now? Can it run alongside my treatment? And can my caregiver join? Keep in mind that hospitals use different labels. They might call it supportive oncology or symptom management, so you may need to advocate for these services regardless of the exact term your clinic uses. Complete cancer care integrates tumor treatment with a medical system that ensures the person fighting the disease feels heard and physically supported every step of the way.